Welcome and good afternoon. Thank you for joining us today. Taking care of yourself is so important. We have been hearing from many of you how valuable lifestyle and stress management tools are. Over the coming months, we plan to offer you more content on navigating mental health. Today's presentation, Depression and Anxiety, Can Cognitive Behavioral Therapy Help?, is being presented by Dr. Anna Bartolucci and Dr. Russell Rosenberg. They are based in Atlanta and looking forward to sharing their insights. At the end of this presentation, they will be answering questions live. So please put your questions below and enjoy. Dr. Bartolucci, Dr. Rosenberg, thank you again for joining us.
Well, welcome everyone. I'm Dr. Russell Rosenberg, Chief Science Officer at Neurotrials Research in Atlanta, so I'm a sleep researcher. And thanks for joining us for this program called Facing Depression and Anxiety in Narcolepsy. Can Cognitive Behavior Therapy Work? And I have a colleague, friend with me today, Dr. Anna Bartolucci, and she is a specialist in behavioral sleep medicine, a diplomat of behavioral sleep medicine, and a clinical psychologist. And we're going to address this issue today. Now, here are a couple of ground rules just to consider. First of all, this is an educational program. We're not here to give any specific psychological or medical advice to any patients. So, you might be asking some questions through the Q&A at the end of the program. And that's great, but we're not going to be able to speak to you directly in terms of what exactly you should do in any specific situation. But so you may hear us talk about things in general, not specific to you. And I understand that might be a little bit frustrating, but I think we'll point you in the right direction, I think, for the most part. And this presentation is recorded. It will be recorded and archived. So if there's something Anna says that's particularly brilliant, which is very possible, you might want to listen to it again and to decide to act on something she might be indicating, or read something she says is worth looking into. So in terms of the presentation today, here are the objectives, the learning objectives. We want to make sure that you understand what cognitive behavior therapy is and how it can be managed or used to manage narcolepsy. Now, we're not saying that narcolepsy by any means is a psychological disorder or psychiatric disorder. What we're saying is that there is a therapy that can help you manage some of the things that go along with narcolepsy. And we'll identify some of the common comorbidities with narcolepsy, things that sort of go hand in hand oftentimes, but not always. And then lastly, and really importantly, is how you find a cognitive behavior therapy provider. And there are some big challenges to this, and Anna and I will address this. And we hope if you decide that this is a therapy you want to go through or explore more about, that will lead you in the right direction to finding someone who is willing and can help you with whatever issues you seem to be dealing with. So Anna, here is sort of the classic Venn diagram, right? We saw these all when we were in high school and college and graduate school. But I think it brings up a good point here, is that, when I was speaking about comorbidities, and these again are things that occur in association with narcolepsy, here's sort of a laundry list. It's not all inclusive, but maybe you could talk a little bit about each one of these comorbidities and how they relate to narcolepsy.
Wow, well, yeah, this is a great diagram, and I wish we could make it 3D so that each of the bubbles touched all of the other bubbles, because it can really get to be a big, complicated thing diagnostically when you're dealing with somebody with narcolepsy as well as the psychological comorbidities. We know definitely that people with narcolepsy are more likely to have depression. There's an incredible overlap there. We also know that anxiety and ADHD are very common, and that I don't know as much about eating disorders and schizophrenia along with narcolepsy. Maybe you could talk a little bit to that. But basically, some numbers. Up to 57% of people with narcolepsy have been found to suffer with depression in some studies. And I'm sure we'll talk about some overlapping symptoms in a little bit, but I think that number just highlights that it's over half. And it's not surprising as we get into it that it is that high, not only because of overlapping symptoms, but because of the challenges they both pose.
Sure. With regards to eating disorders and schizophrenia, I'm not sure I have much more information on that, but I think it just speaks to the fact that narcoleptics are vulnerable to other psychological behavioral disorders, whether it be through, as a result of having narcolepsy, or just as a result of being human, for that matter. So,
brains are weird.
Yeah, let's talk a little bit about what cognitive therapy, behavior therapy is, because it's not absolutely clear. I think you and I know this acronym CBT, and you often hear professionals throw around acronyms without much explanation. So why don't you take a crack at what this is and what it's based on?
Sure. So cognitive behavioral therapy is a beautiful therapy because it focuses on different aspects of the problem. So if you think about it, when you're dealing with anxiety, depression, sleep problems, like in my practice, we see a lot of insomnia as well as hypersomnia. There are three parts. There are the emotions or the sleepiness or the sleeplessness themselves, and the thoughts, the behaviors, and they all feed into each other. And as you found, you can go after the emotions and sleep symptoms directly with medication. However, for a lot of people, medication doesn't necessarily get them all the way there. There might be side effects. Other reasons it's not the whole answer. And so in cognitive behavioral therapy, we focus on changing feelings and experiences through changing thoughts and behaviors, which are a little bit more under conscious control. I mean, behavior change is hard. It's hard to change our thinking, but it is possible. And the core principles on here are definitely accurate in that if you look at it broadly, we all have this negative cognitive bias. It's hardwired into us for survival. We are hardwired to look for cues of things that might be threatening. So, back in the day, it was things that wanted to eat us or things that wanted to kill us. But now the brain tends to still blow up the drama of our everyday experiences and react in similar ways. Because our brains and our bodies, again, our brains are weird. They have not necessarily evolved or caught up with modern life. And so they have reactions that are maybe still a little bit left over from the olden days.
So this idea of, I think I understand the behavior therapy part, but I think that the cognitive part often confuses people, I think, because they're not quite sure. How do you change your thinking? I think that seems so easily said, but it's much more difficult than that. And there's really a process, correct?
Definitely. Yes, it is absolutely a process. So it is looking at the thoughts themselves, seeing what parts of the thoughts are leading to the negative emotion and what the mind is doing to perhaps exaggerate those parts. For example, one of the patterns of thinking that's very common is all or nothing thinking, because our brains are kind of lazy and they want things to be one way or the other. Our brains don't do well with shades of gray in the middle, but that can get us into trouble because either you're perfect or you're a failure. And so with cognitive therapy, we help to dig out some of those distortions, to label what we're doing, because it helps to start giving us some distance from it, and then also to work on questioning it and generating rational responses. And all of this is done through written homework. And the reason for that is that we believe things that we see and are generated externally more than we do things that we generate internally. That's why we are going to remember an insult from somebody else more than we are going to remember the 100 affirmations we did that morning, because external versus internal negative cognitive bias.
So there's homework involved, and there's some exploration of what, or identification of the thoughts that might need to be changed. I'm just wondering, again, since I think the cognitive part of this is a little more foreign than some of the other parts in terms of changing behavior, what might be a good example of a negative cognitive internal thought, like you were mentioning all or nothing thinking. So somebody could say to themselves, I'm never going to achieve the career I need because I have narcolepsy. Would that be a good example of one?
Yes, that would be a great example, because I think that's a very common thought for people with narcolepsy or any other kind of chronic health condition is, oh, this is going to limit me. I'm never going to be able to do what I want to do. And so anytime you have an always or never, there's that all or nothing thinking. And there's also a bit of what we call overgeneralization, which is the way things are is the way things are always going to be. So
no, go ahead. And I was just kind of interested in how you would pull that apart or pick that apart to make a change.
Right. So what we would do is we give patients a list of questions to ask. And there's 20 in the format that I use. I'm sure other cognitive behavioral therapists, we all do generally the same things. They might have slightly different materials. And so we would have the patient question, okay, what is the evidence for this thought? Sure, you're limited now. Are you underestimating what you can do to solve the problem or situation? Is there more information that you need to be able to figure this out? And so it's not saying yes, you will or no, you won't. It's, well, let's talk about this further. Let's at least put you in a place where you're in a position to be able to explore the possibilities more objectively.
Okay, good. So in what way does CBT, cognitive behavior therapy, differ from other forms of psychological therapy?
Well, a lot of times people hear psychological therapy and think they're going to come in and lay on my couch and talk about their mother.
Do you have a couch in your office?
I used to.
You used to.
And I may or may not have taken many a nap on that couch. It was very comfortable.
But patients don't usually sit or lie down on a couch, is what you're saying.
No, so that's the old model of psychoanalysis where they, the psychiatrist or therapist sits behind the patient, they don't see them and they have them free associate. That is not cognitive behavioral therapy. With cognitive behavioral therapy, it's very structured. And so it's definitely going to be more than, hey, tell me about your week. Tell me what's going on right now. There is some of that, but it's like, okay, let's figure out what's going on specifically and what your mind is doing to make life more difficult for you, basically. It's also time limited. One of the really nice things about cognitive behavioral treatment is that you won't be in therapy forever, which is another fear that a lot of people have about therapy is that, well, I'm going to have to go talk to this person for years to get fixed. Our general model for cognitive behavioral therapy is 10 to 12 visits and spaced 1 to 2 weeks apart. So it is a nice, short, time-limited therapy. It's also very well research supported. So that means that there has been lots of data showing that CBT is very effective for lots of things, including insomnia, depression, anxiety, and now with a new protocol, even with disorders of hypersomnia.
Okay, that's a great description. So, if someone wants to enter therapy, are there topics you can and can't discuss in therapy? And give some examples, if you would.
So I would say that anything is fair game for discussion in therapy. I've had patients who come in for one thing, we end up discussing another thing. Examples might be, so with somebody with narcolepsy, one of the big questions that people tend to have is in comparing themselves to somebody else is like, well, my friends have no problem doing this thing, whether it's, let's just say getting the laundry done. Why can't I do household chores like getting the laundry done? And so, we talk about that. We talk about how why questions are actually should statements in hiding. So I should be able to do things like other people. And help the patient say, okay, where are you holding yourself to maybe an unrealistic or unobtainable standard with this issue? And, we can also talk about, well, what was it like to get diagnosed with narcolepsy? What was the journey like? Because a lot of people have had the experience where they had lots of fits and starts and lots of false trails that they went down to before they finally got the diagnosis that explains what's going on with them. And we also talk about things like, well, how does this make you feel about yourself? It's kind of a cliche that psychologists ask, how does that make you feel? But we do sometimes. Sure. And then, coping skills are a huge part of it. How are we going to help you deal with all of this stuff? And we do encourage people to have social support because humans, especially as we found over the past couple of years, humans are socially affiliative creatures and we need connection with others for support.
Yeah, support like the Narcolepsy Network. I think yes. that many people don't realize, what an organization like that can do to learn new things and help bolster their their self-identity and self-image as well. I'm wondering about the cognitive behavior therapy for hypersomnia. There is a set of guidelines, if you will, or a set of issues around that. But before we talk about that, let me ask you: do you have many narcoleptic patients that find themselves angry about their journey, and how would you manage that if it did take somebody 10 years, which is, I think we both know, and everyone on the call today and the webinar knows that it can take up to 10 years or more to get diagnosed. I mean, how do you manage something like that with someone who's still struggling with that whole frustration experience?
That's a great question. And part of what we do with cognitive behavioral therapy is helping people with things like self-compassion, because a lot of times with that journey, it's, well, why didn't I do this? Why didn't I do that? Why didn't I figure this out sooner? Mm-hmm. And then also looking at the thoughts that are maybe not so useful. The thoughts might be true, that that, or the other provider should have done something differently, but it's not necessarily useful to spend the energy on that part of it. So there is a little bit of working with people on acceptance of, okay, well, this is what happened. Where do we go from here?
Yeah, I know, having known a lot of narcoleptic patients over the years, I know some of them are frustrated because it's hard to talk about their symptoms to a loved one or a family member or even a friend because they don't seem to understand. So that sense of social support may not come from inside their circle of friends and family.
Mm-hmm. So that would be.
Go ahead, I'm sorry.
So that would definitely be another area to focus on and to talk about, which is, okay, and how can you better communicate about your needs and your experiences to your loved ones? And if you find somebody who's being dismissive or, oh, just try this, oh, just drink more coffee, how do you handle that in a calm and assertive and effective way?
So one area of CBT, or you can tell us if it's part of CBT or something else, but that is the topic comes up of mindfulness therapy. I think that's something that has made the popular press a lot lately, but I also know that there is some data out there that shows that hypersomnolence patients could even benefit from that. But what is mindfulness therapy, and why do you think it can help narcoleptic patients?
So the key of mindfulness therapy it's actually two keys. It's awareness of what's going on internally and externally in the moment. And it's approaching that awareness with a non-judgmental attitude. So, okay, this is my experience right now. I'm not going to say it's good. I'm not going to say it's bad. I'm just going to accept that this is my experience and this is valid. And so, yeah, what the cognitive behavioral treatment for the hypersomnia has done is to bring in some of these elements so that it can help to augment and complement what we do in traditional CBT. And so when we do mindfulness therapy, basically it's working on focusing on the present. It's working on that non-judgmental observation, which is so important. Because if you think about it, a lot of times people with narcolepsy, they have a smaller energy bucket. And so they have to be very careful on how they spend it. And so mindfulness practices and techniques can be very useful in helping people to say, okay, yeah, this sucks, but I'm not going to spend my emotional energy over here. It's more important for me to spend it here and to engage more in values related activities and effort.
Sure, I think it could certainly be an important component to therapy. Is mindfulness therapy or mindfulness as a practice, is that something you need to go see a therapist about, or is it something you can read about and do like bibliotherapy? That is where you read about something and then you start practicing it.
Yeah, another good question. If you think about all of the self-help books in all of the bookstores on all of the online retailers, no matter how many of them there are, psychologists and therapists will always have a business. And the reason for that is that, yes, you can get some of these, or maybe most of these things out of books, but what you're missing is the accountability, the encouragement, the direction. Like, where do we start? Because there's a lot out there. And maybe even to the degree of, what is a good reputable mindfulness app that I can use that doesn't cost a lot of money or that's free?
What about relaxation therapies in general? And I won't put hypnosis into that. Maybe we'll deal with that independently. But can a narcoleptic patient practice relaxation therapy without falling asleep, or use that sort of therapy that you use in CBT, effectively and safely?
That's a really interesting point. So I have definitely had the experience in my practice where when I've been working with patients with narcolepsy, they have very mixed reactions to relaxation and mindfulness techniques, actually. So I have to be very careful with who I use it with and how I use it. And so it's a very individual thing as to how people will respond to it. Are people going to end up feeling more tired and groggy afterwards and it's going to make the rest of their day harder? Then probably not a useful thing to practice during the day. Maybe that would be something to practice at night before bed, especially if they have anxiety around bed and bedtime. Whereas in other cases, if people are able to tolerate them and are able to practice them more during waking hours, then they can be very helpful for the experience of anxiety and just helping people to manage the overall stress of having narcolepsy.
Sure, I think that's really helpful. What advice do you have for people joining us today about finding a CBT therapist, somebody who can really help them?
So definitely it would be asking a lot of questions. And so questions might be, have you ever worked with somebody with narcolepsy or a disorder of hypersomnia before? How did they do? How do you typically approach them? Like, I know for me, before this new treatment manual came out, my strategy was always, well, let's help you get the best sleep you possibly can at night, because we know that people with disorder of hypersomnia are actually getting kind of crappy sleep at night. And then how can we also help you to manage the daytime stressors so that you are using your energy budget in the most effective way possible? And so maybe looking for somebody who says something that resonates with you that might sound like it would help your particular problem and your aspect of the problem, because while people with narcolepsy and disorders of hypersomnia have a lot in common, everybody's still an individual. And I think that's one of the things that makes sleep disorders so much fun to treat, is that we do have these great things that work, but it's the creativity of figuring out, okay, how does it apply to this particular person and this particular case? So if you're looking for people who you know have been vetted, have gone on for the extra certification, now it's called the Diplomate of Behavioral Sleep Medicine, the DBSM, then go to the Society of Behavioral Sleep Medicine. The website is behavioralsleep.org. And they have a state-by-state listing, as well as listings of providers in other countries. And if you're in a Psych state, which is an interjurisdictional compact that some of the states, well, actually most of the states, I think at this point in the country have entered into, you can do telehealth with a provider who's in a different Psych state. So that's really helped to open things up. I haven't really integrated that into my marketing yet, but I definitely do plan on that soon. So for example, I could see a patient who is located in, trying to think of a good one. Oh, I was just talking with somebody about this, located in Washington, DC, for example. So behavioralsleep.org, the Association for Behavioral and Cognitive Therapy, ABCT, also has a provider directory, and I believe they do also have a sleep section or a sleep potential listing. And yes, don't allow fear of driving, for example, to keep you from reaching out to people, or somebody being located far away, even in your own state, because yes, most of us, especially at this point, are still doing mostly telehealth, and we are very comfortable and very good with that particular modality.
I want to come back to telehealth in a minute, but if someone's looking for a therapist like yourself, are you going to be able to take enough time with them to give them a sense that it's a good fit? Do you spend time talking to the patient before they make that first appointment, or what do clinicians usually do?
Typically, we get that sort of information at the first appointment, because otherwise we would spend all day on the phone instead of seeing patients. So, but just keep in mind that that first appointment is as much an opportunity for you to evaluate a particular therapist as much as it's an opportunity for them to evaluate you.
This is some questions just about therapy in general, not so much for narcoleptics, but is gender sometimes a preference? Like, do some people say, well, I'm a woman, so I want to see a female therapist, or I'm a guy, so I want to see, or vice versa? I mean, it doesn't, do people have preferences for therapists?
Yes, definitely. And, and if you do, that is perfectly okay, and that is perfectly valid. Like some people would prefer to see a physician of the same gender, or, depending on the preferences of the opposite gender for certain things. So yeah, no, it's perfectly fine to have those preferences. If you are a part of the LGBTQ community, it's fine to seek out therapists who, are friendly to your community. Similarly, people sometimes have a preference about race. So, a lot of times people will have on their websites whether they are, they fit well with certain populations, or, their characteristics that certain populations might be looking for.
So I've had some patients ask me about what they say to the therapist. Is that, is it confidential? Are you obligated to, if they've been referred by, say, a physician, are you obligated to report everything that they tell you about? If they're asking about issues tangential to their narcolepsy, do you have to report all of that to the physician, or would you?
Not necessarily. And we do ask at the first visit, and we also have it in writing in the intake paperwork, is it okay for us to send notes and to communicate with your referring physician? And some people say no, and that's fine. We'll ask, well, can we, at least send your physician a thank you note for the referral? Sometimes people say yes, sometimes people say no. And if they say no, then there is no communication that goes back to the referring physician. And that is fine. The only exceptions to confidentiality are if you tell us that you're a danger to yourself or someone else, we do have to take some action. We are also all mandatory reporters, so we do need to report if we hear anything about child or elder abuse. But beyond that, it's fair game. If you tell us something and then you're like, well, no, I don't want that to be in the note. Sometimes people tell us that about certain substances. That's fine. We will leave it out of the note, or we'll put it in different language. Like I have a lot of patients who don't necessarily want me to be super direct about the herbal remedies they're taking.
Right. It's, but I think it's important for people to know who are seeking out this sort of therapy that it's a confidential relationship. Let me go back to how you choose the therapist just a little bit. What's the training if someone wants to connect with a therapist and make that a first appointment? And what are some things to be looking out for in terms of training or licensing or other experience to know that they're going to be a good source?
I have to admit, I don't know that much about training for master's level therapists and what their requirements are. I do know that some of them are required to be licensed, some of them are not. For those of us like me who are doctoral level, that means that we either have a PhD or a PsyD in psychology of some sort. So mine is in clinical psychology, some might be in counseling psychology. And otherwise, I would definitely look for somebody who has been certified by the Board of Behavioral Sleep Medicine, or earlier the American Academy of Sleep Medicine. That was our original certification, the CBSM. And that way, that people have had extra training in sleep disorders, because as you know from having one and from the journey it sometimes takes to get diagnosed, that not all providers are versed in this topic.
Sure. I think that makes sense. I think there are some, just to make sure everyone knows, I think there are some qualified master's level therapists who've worked with a sleep disorder center. And the same is true with nurses or nurse practitioners who've had either some training along the way in therapy, because it is, it's not something you just, or not you specifically, but it's not just something a therapist, picked up. There is professional training and ongoing training involved. Oops, so let's go one more here. Sorry. I want to go back a little bit. So we talked about some of these common questions, but going back to the telemedicine, and I know you're very experienced about this because you were sort of forced into it in some ways with COVID, although I'm sure many, in Atlanta where you can drive hours to get to a therapy or a doctor's appointment, it's a highly valuable tool. Are there any pitfalls to doing your therapy over Zoom or whatever platform, a virtual platform?
I would say the hardest thing about doing therapy over telehealth, and I just want to say that, can it be done via a Zoom meeting? I might use Zoom as a backup, but it's not my preference, because unless you pay for a certain level, you don't necessarily have the security that you do with a formal telehealth platform. So the one that we use is actually integrated into our electronic health record system and has that level of security for confidentiality reasons. So I guess that would be one pitfall, is if somebody is not using one that is completely secure. I would say another thing, and that's the hardest thing about doing teletherapy, is that it's a lot more work for the therapist, because if you look at us right now, you can see us from about here up. And so you can't see our legs. I'm half Italian, as you can probably guess from the last name. That's mine, that's not my husband's. So you can see, from the waist up, you still get a lot of gestures. you get a lot of nonverbals. That's not necessarily the case for everybody. And so it's a bit more work trying to extrapolate the information that we would get from a whole body view from, I would say, probably about only 60 or 70% of the information. So I can't do as many telehealth visits during the day as I can in person. That's the hardest part for us. The hardest part for the patients is sometimes, okay, if they don't have a great internet connection, they might have to move their location within their residence, or they might have to switch to a different device. So sometimes there are tech issues. At this point, 2.5 years in, we've gotten pretty good at solving tech issues fairly quickly because we've had to. Sometimes we'll just do a phone session as a backup. So, that's, again, not preferable because then you really aren't getting any nonverbals, but still, it works in a pinch. Other than that, other pitfalls might be, you don't necessarily get the same level of eye contact. Although there was a recent study showing that for at least cognitive behavioral therapy for insomnia, and I would guess it's the same for the other kinds of CBT, it is possible to make the same kind of connection between therapist and patient as it is in person. And I've definitely found that to be true. I haven't really found, except for maybe a couple of exceptions, that it's been hard to connect with people.
So this last question before we wrap up and let others chime in with their questions and our answers is an important question because, well, for a variety of reasons, I think everyone understands, expenses for medical and psychological care can be daunting in some way. So do most insurances or do some insurances cover therapy, and at what level?
Because there are so many different insurances and then so many different plans within insurance companies, I can't really make a broad statement as to what level things are covered. If a provider is in network for an insurance company, then yes, typically they will cover therapy as well as teletherapy for sleep disorders. With narcolepsy and hypersomnia being medical diagnoses rather than mental health diagnoses, we might end up having to file under a comorbid condition such as anxiety or depression. So please do keep that in mind. But I'm guessing if you're going to see a therapist, you probably do qualify for one of those. And even if insurance doesn't cover therapy, then a lot of times providers will see patients on a sliding scale. And also please do keep in mind, it's not forever. It's a time-limited treatment. And even if it ends up costing you some money out of pocket, think about it as being maybe one of the most important investments you'll ever make. And at this point, with cars being as they are, of course, this therapy is still less expensive than, shall we say, a mid-level car repair.
So therapists are not put off by patients asking if there's a sliding scale, and in some way you assess that, and we'll discuss that with them.
Yes, we'll definitely discuss that on a case-to-case basis. And in some practices, like in mine, there are 2 other providers who work with me who do see patients on a sliding scale. I personally do not, but my colleagues do. And I can attest that they're both great, and they would be great therapists for somebody with hypersomnia or narcolepsy.
So we covered most of these other questions. I think this was terrific discussion. And then I can't think of anybody better to answer all these questions about CBT, whether it be CBT-I for insomnia or CBT-H for hypersomnia. I appreciate your insights and your discussion about these. So we'll get to the questions here, unless you have anything else you'd like to add before we do that.
I think one thing that we hinted at that we didn't necessarily get back to was, what are some of the ways that having narcolepsy or hypersomnia sets somebody up for depression. I think we alluded to it a little bit with the thoughts, but basically it's the difficulty with accomplishing daily tasks, maybe some of the extra difficulty with time management and having to manage long sleep periods or naps, the difficulty with trying to explain and get accommodations from an employer, for example. That can be very tricky. And that's also something that we can definitely help with. We can even write letters for employers. I have definitely done that in the past. So, whatever aspect of the problem there is, it's likely that we can help you figure it out, or at least direct you to the resources to help you to figure it out. So I wanted to say before we end, thank you so much for the opportunity. Thank you, Narcolepsy Network, for inviting me and us to do this. And thank you, Russell, for the wonderful discussion. That was a lot of fun.
I have just one thing to end with, Anna, and I think that this is just as much for the family and friends of as well as those who indeed have narcolepsy. And this, I think, pertains to the, cognitive behavior therapy idea in some respects. And that is, one person's, productive day, or most productive day, might be somebody else's least productive day. So it's there's a lot of relativity here. I think that and since there's so many variations on the theme of disorders of hypersomnolence, either the patients need to cut themselves some slack just because they can do what they can do, and that's the best they can do often, and the family members and employers as well. So thanks again, Anna, and we'll get to the questions now.
Hello, everybody. So as you can probably tell from my wardrobe change and the fact that I actually have more of a voice now, Dr. Rosenberg's and my conversation was recorded a few weeks ago. And I wanted to tell you guys that unfortunately he had something come up today. He was not able to make it. And so I will be attempting to answer your questions. We have 4 appropriate questions in the Q&A at the moment. And if you have any other burning questions that were not answered during the presentation, please feel free to put them in the Q&A now. I would also like to put out a couple of disclaimers. So first, I am not a physician. As you can see, my degree is PhD, so I can't answer much in the way of medication questions. So I can't give you opinions on certain medications. Also, I can't answer questions about your specific case because that's going to be between you and your provider. So as Dr. Rosenberg said at the beginning of the presentation, we're going to keep things a bit more general. All right, so let's go on to the questions. An anonymous attendee asked earlier in the presentation, how is the CBT process different for people with insomnia versus hypersomnia? And then another anonymous attendee, maybe the same one, asked, what is CBTH? So just to give you guys a review, because I know that was a lot of information and a lot to keep in your head. In CBTI or CBT for insomnia, we're focusing on the thoughts and behaviors that maintain insomnia with the aim of helping patients to move past insomnia. And basically, we are trying to address or cure the insomnia itself. So our goal is to have people sleep whatever number of hours they need to feel refreshed and to be able to function well during the day. And our hope is at the end of insomnia treatment that our patients will not have insomnia anymore. And also that they will be completely off any medications for insomnia. In cognitive behavioral treatment for hypersomnia, which I admit I'm a little less familiar with, even though I've been treating patients with narcolepsy and hypersomnia for years now, there's actually a new treatment manual that we are working on studying and integrating into our practice. As you guys know, narcolepsy and hypersomnia are chronic conditions. And so there is no way through cognitive behavioral treatment that we're going to be able to cure you like we aim with our insomnia patients. And so the process is a little bit different. As we talked about how, and maybe we'll talk a bit more about the diagnosis and treatment journey. There's also more mindfulness and an acceptance and commitment therapy elements brought in, such as accepting limitations that can't be overcome or worked around, or, we do talk about coping and working around limitations as well as much as possible, accessing resources. What I used to tell my patients, and I think this still holds, is that our aim for our narcolepsy and hypersomnia patients is to get the best sleep that you can at night, and then be better able to manage your stress and better use and protect the limited energy that you have during the day. All right, we got some more. Another anonymous attendee asks, for people with cataplexy, is biofeedback therapy an option? That is a very interesting question, and I will admit, I don't know. I'm sorry. I bet Dr. Rosenberg could have answered that one. So perhaps we'll be able to get him to pop into comments to say something about that. Rachel gives us a compliment, thank you, and says, in my experience, do I see CBT for disorders of hypersomnolence playing a part in treatment, medication compliance, and even treatment response? Definitely in terms of treatment response, because if you think about it, if you are on stimulants during the day or on sodium oxybate at night, but you still don't have all the other pieces in place to help to support your sleep, to help to support your lifestyle and manage your stressors, and maybe you don't have the tools to be able to protect the very small, very precious energy envelope that you have, then the medications aren't going to be able to work as well. It's an interesting thing I find with some of my insomnia patients, wherein as we start treatment, their medications actually start working better. So I would imagine, and actually have seen, that patients with narcolepsy and hypersomnia, once they start using some of the tools and the strategies, their medications start working better as well. And as for compliance, it's a lot easier to be compliant with something that's actually working. Somebody asked, what can we do to help ourselves while we search for a provider? Well, the Narcolepsy Network has tons of resources for you, as do the American Academy of Sleep Medicine and the Society for Behavioral Sleep Medicine. There was one question that I wasn't going to answer directly because it had to do with resources for finding treatment. One option would be, if you can't afford treatment, to see if you can find a clinical study on CBTH, because with it being a brand new treatment modality, I'm sure there's going to be a lot popping up, or a behavioral sleep medicine training program where students would be able to see you at low or no cost. There's also things that you can look into that might not necessarily be focused on narcolepsy or sleep, but are rather more mindfulness-based techniques. Those are always good to get under your belt. And one brief note about mindfulness is a lot of people think that it has something to do with clearing your mind. So they're like, I'm not good at it. Mindfulness isn't about clearing your mind. Mindfulness is about noticing when the thoughts are wandering and bringing them back, and doing that over and over again, which then helps to manage emotional reactions, and again, helps you to maintain and protect your energy budget. All right, so somebody asked, can you use my services if you live out of the area, as long as you're in a Psych state. Thank you, I appreciate that. How is CBT different for people with narcolepsy? I believe I did answer that one. So Melissa, if you missed it, it would be a good idea to go back and to watch the recording. I know, so I'm a space cadet. I understand sometimes you slip off in the brain and you miss things, but I promise it is there. So somebody asks about emotion regulation in the evening as medications are wearing off. I would say that is also a great thing to bring up with a behavioral health provider. There's also an area of therapy called dialectical behavioral therapy, and they have a whole section on emotional regulation. But I say even maybe looking up emotional regulation and again, mindfulness is fantastic for that. Oh, Bonnie has the million-dollar question. How do you explain narcolepsy to people who don't believe it exists and just think we're lazy? That's the question that a lot of us who are neuroatypical, and I include myself, I will confess to you guys that I have ADHD. How do you make people believe it, especially if you seem to be able to function well during the day, and so they're not actually seeing the difficulties, or like you said, they're lazy. So you could perhaps bring them some resources, maybe from the Narcolepsy Network, on explaining, okay, this is exactly what it is. And you can describe it as a brain disorder, which means you don't actually see it, but you see what's manifesting. But yeah, Bonnie, I admit that is going to be an ongoing conversation, and CBTH, cognitive behavioral treatment for hypersomnia and narcolepsy, that falls under that. There are resources in there, I believe, on how to communicate your condition to others. Right, and then somebody asked about how does mindfulness differ from CBT? CBT and mindfulness are two different treatment modalities, but they are often braided together. And so I will often use elements of both with my patients. I'm loving this. This is like a lightning round. All right. Do I have any experience with CBTH groups? No, actually, although I think that is something that I would definitely like to implement. Just, again, since the manual is so new, we haven't had the chance to roll a lot of it out. And good luck getting the diplomat, Anna. Does the therapy work with patients with narcolepsy that don't have any type of insomnia, just depression and headaches? Yes. I'm sorry, I talk a lot about insomnia because that is most of what I see. As you guys are probably aware, insomnia is a bit more common than hypersomnia. But yes, the CBT for narcolepsy and hypersomnia does work for if you just have that, if you have that plus a couple of other things, if you have that plus insomnia. So all combinations are welcome because you're basically using the same core principles and applying a lot of the same skills in different ways to the different elements. But that's one of the things I love about cognitive behavioral treatment. It's that we are able to tailor it to different patients. And that's both a challenging and also very fulfilling way of doing therapy, is to make it individual and to see how individuals respond to different things. And sometimes you need some flexibility, and that's great. A good mindfulness app that's free. Yes, my absolute favorite is called Insight Timer. So INSIGHT space TIMER. It's available across all platforms. And there are, I want to say gazillions because it seems like there's gazillions. There are thousands of free meditations on there. They're adding more all the time. They have a paid level, but the free level has more than enough access. And it also has a really cool timer function. The multi-state entity I mentioned for providers to see patients in other states is called PsyPact, PSYPACT. And so if you live in a PsyPact state, you can see providers who are licensed in other PsyPact states. And this is an entity that's growing all the time. For example, being in Georgia, I'm in Atlanta, I've been watching the different states around us get it. Florida, unfortunately, the legislation died this year. Hopefully it'll come back. South Carolina, it was approved, and they're just waiting to be approved by PsyPact, which gives me everybody in the ring except for Florida. And also apparently New York has introduced legislation, which is amazing because I thought that they in California would be the last ones. And of course, California, probably not going to do it. Is it better to have a separate CBT provider who specializes in narcolepsy and chronic pain, and then another to deal with ADHD, anxiety, depression, etc.? I would say that depends. I know that's not the answer that anybody ever wants to hear. Like, that depends, and also you're an interesting case. That is also something nobody wants to hear. So I would say it depends on the complexity of the case, and it just depends on how much time you need to spend addressing these different issues with each provider. Some providers, if they are very efficient and if you're able to keep on track with things, maybe one-stop shopping is for you. However, sometimes these problems are too big to handle more than one of or more than two of, and in that case, you would need a different provider. So, sorry, that was kind of a vague answer, but the best one I can give. More about CBT for depression and anxiety, please. All right, cognitive behavioral treatment was originally developed in the 1970s to help with depression and anxiety. That was sort of the core thing. And so the process is, as I described, where you're looking at the maladaptive thoughts, you're looking at the behaviors that are maintaining it. So for example, people with anxiety tend to avoid what they're anxious about. People with depression tend to, well, avoid everything, but withdraw, isolate. And so CBT addresses those things as well as the distortions, which tend to have different forms, but tend to be common across disorders, including insomnia and hypersomnia. So hopefully that clarified. All right, so making sure that people in the chat weren't telling me it's time for me to be quiet. All right, I'm Lola, I have no idea. So I'm going to go ahead and skip that one. Is it common that people with narcolepsy also end up having insomnia regulating sleep schedule? And then not going to address your specific case. Honestly, in what my former mentor, or even his current mentor, Michael Bruce, used to say, some people have that interesting combo platter of diagnoses of insomnia and hypersomnia. And oh, here's my cat. I figured he would show up eventually. This is Timothy Mouse. He sleeps fine. So I don't think you would necessarily need different providers for cognitive behavioral treatment for insomnia and hypersomnia because they are both behavioral sleep medicine problems. And so I typically work with both at the same time. Okay, and somebody's asking which psych meds interfere with sleep. That is also a hard question, not only because I'm not a physician, but because brains are weird. That's one of my favorite expressions. I'm going to start getting it on t-shirts. Brains are weird. And so somebody might take one antidepressant and it makes them sleepy. Another person takes the same thing and it wrecks their sleep. So I can't really make a broad answer. It's working with your provider to figure out what works best with your brain. All right, so that was our last question. Thank you guys for the great participation and for the questions. And now, again, thank you so much for the opportunity to do this. And I'm going to turn it over to Amy for our final comments.
Thank you, Dr. Bertolucci. You did a great job answering all of these questions. It seems like there were many, many questions that were quite relevant and some that I hope that if you didn't get them answered, that we can answer them in the future. Thank you to Dr. Rosenberg as well. Unfortunately, he was unable to make it. We had quite a lively discussion. If you haven't already seen information on our conference in Atlanta, please visit our website. We will have more presentations on mental health and resources. As well, we would very much appreciate it if you have a few minutes to fill out our evaluation form so we can continue to provide relevant content for you in future webinars. So thank you all and have a nice evening.